Good afternoon, everyone. My name is Emma Kalk. I'm working at the Centre for Infectious Disease Epidemiology and Research at the University of Cape Town. On behalf of SCAN, I'd like to welcome everybody to this webinar. We have two speakers discussing pediatric surgery today, Professor Emmanuel Ameh and Dr. Philip Kisa. Before they do, I'll just remind everyone about SCAN and our remit. We're going to, I'll give you a bit of information, and then we'll have our two speakers and a discussion just around 3 o'clock. And then if you hold on for an additional sort of 20 minutes, we're going to be launching the SCAN website, which you're welcome to attend. Just some housekeeping. The workshop is being recorded and will be shared on the Global Health Network platform. And if you want to use the chat box for introductions or technical issues, and the Q&A box for posting your questions about specific topics. Due to the number of participants, the camera and the microphone have been muted. But if you would like to speak and are invited to do so by the chair, if you raise your hand, and then we will enable the microphone. And once again, use the chat function for any technical issues. Okay, so just by way of background, the SCAN, or the Sub-Saharan African Congenital Anomalies Network, is a project to establish a network which has been funded by the UKRI MRC. The primary aim of the network is to improve the diagnosis of congenital anomalies and care for affected children and families, and to promote identification of etiology. And this we hope to do by building an evidence base through surveillance and research, improving capacity for collaborative research, and paving an impact pathway on policy and practice. The network was establishment is led by a team of co-investigators working together with partners from 10 African countries, the UK and the US. And together we will establish this network to build capacity by training health professionals via webinars and other resources. We're also sharing expertise. Today is the 5th SCAN webinar, and our focus is on care of children with structural congenital anomalies and the impact of pediatric surgery workforce on gaps, surgically correctable congenital anomalies in sub-Saharan Africa, and the early identification of correctable and life-threatening congenital anomalies. Okay. So I'm going to introduce our first speaker, who is Dr. Philip Kisa. Dr. Kisa was born and raised in Uganda and completed medical school at Makerere University in Kampala, and worked as a junior doctor at St. Mary's Hospital, Lakor in Uganda. She received an M.Med in general surgery from Makerere University and a fellowship in general surgery from the College of Surgeons of East Central and Southern Africa. She has completed a pediatric surgical fellowship as part of this college, as part of a hybrid training course between Uganda and BC Children's Hospital, where she trained in pediatric surgery and pediatric urology, and has also completed a formal clinical fellowship in pediatric urology at BC Children's Hospital in 2018. Dr. Kisa currently works in Uganda, where she's a lecturer in pediatric surgery at Makerere University in the College of Health Sciences in Uganda, and an adjunct professor at the University of British Columbia in the Division of Urology. Her interests include training and collaboration in pediatrics, specifically pediatric urology, and has a strong interest in research, particularly into perioperative nutrition, which was the focus of her M.Med. She, in addition, is a stakeholder in terms of the children's surgery and anesthesia in Uganda, and collaborates with local and international partners in programs to improve research and surgical capacity in Uganda. So I'll stop sharing now. So thanks, Dr. Kisa, if you want to share your slides.
Good afternoon, everyone, and thank you for inviting me. It's an honor to be able to present at this webinar, and I'll focus on the early identification of correctable life-threatening anomalies and the Pediatric Emergency Surgical Course. So I just want to let you know that some of the people in here may not be surgeons, but there's going to be a few pictures of babies or children with anomalies. So, I mean, this is the right forum to present them. So despite the global reduction in newborn mortality over the last decades, the rates remain very high, and the reduction much lower in lower and middle income countries compared to high income countries. Many of these deaths have been attributed to correctable structural anomalies, which predominantly occur in LMICs. Most global efforts, as we all know, have been geared towards infective causes of death in newborns, tetanus and things like malaria, TB, HIV transmission, and very little effort has been towards things like structural anomalies. At the Pediatric Surgical Unit at Mulago Hospital, where I work, we've had a prospective database since 2012. And from this, we found that newborns are about 28% of our admissions, with an overall mortality of 36%, and with the 24% mortality in those undergoing surgery. Most of these children present at a mean age of 3 days, but they present from hours from delivery to some showing up to even 3 weeks. You'll be surprised that we see a lot of esophageal treasures mostly presenting at an average of 10 days just for that condition alone. And we know that seeing them earlier or having them identified before they're born is really a key factor in having them survive better. And for example, just a condition like gastroschisis, which is, I mean, it's thought to be rare, really. Its incidence is increasing globally, but of these children, it's 17% of newborns admitted. It tells you that the numbers are either more or if we really kept track of everyone, we might realize that the condition is not as rare as we thought, and maybe we're having the same trends here in our anomalies as compared to the rest of the world that's keeping track. And rarely do we have prenatal diagnoses of structural anomalies, with most babies being born out of tertiary facilities. They have having delayed presentation. And for most practitioners in sub-Saharan Africa, a lot of patients believe in out-of-hospital deliveries because they seem to trust traditional birth attendants more, or just a home delivery without modern medical intervention. And so a lot of children might be born with congenital anomalies and they don't get identified. Anecdotally, we know in Uganda and probably in some of the other countries, I know South Sudan as well, there's a lot of infanticide for children born with gross anomalies. And when we do see a small percentage of them, there's probably a huge iceberg beneath the water that is actually dying out there in lower facilities, but also not being born in places where they can be identified and referred. The other problem that we face with this is there isn't a proper checklist for an anomaly scan except for obstetric details. For example, when antenatal ultrasound is performed, they'll give the depths of liquor, the insertion of the placenta, and they'll give the ramp length, head ramp length of the baby, but frequently even if there's bowels floating in the amniotic fluid, it's very rare that it's going to be mentioned in the scan. If there's something going on with the ventricles in the brain, again, spina bifida, again, some of these things, they don't get mentioned even when they seem to be obvious. Part of it is because the training has not focused training our sonographers and radiologists in reporting in this way. And there is also no clear checklist for them to really check from head to bottom and really check that everything is there. So even when something is being seen, some people might not recognize what they're seeing and don't know what to report it as. The others, the priorities are in a different area, so they report those. Like a child could have a huge sacrococcygeal teratoma and they'll not report that, but the sonographic result will tell you it's a boy or a girl, while not telling you this huge anomaly that is there. This really compounds the later identification and referrals. So the few that do get scanning, those that require that they're born in a tertiary facility, we don't see those, and everyone gets surprised when the baby is born. And then there are others whose conditions might be identified by ultrasound and then that don't show outside on their bodies. For example, esophageal atresia, bowel atresia may show on ultrasound, and these they get identified after so many days. The children have been feeding, probably aspirated, they decompensated from all their losses, yet having them identified earlier might have helped by them being born in the right place. Or being flagged for the pediatric surgical teams and neonatal teams to watch out for them. So like I said, that there's no anomaly checklist that we currently use. And I think a lot of other countries do face the same thing. There is nothing formalized in this way. Things like bilious vomiting or urinary tract infections in children usually spell a structural anomaly until proved otherwise. But you'll be surprised at how long it takes other medical workers at all different levels to be able to transfer these children to a pediatric surgeon. So many times it is something structural, but they never get flagged down. And many of these could die before even they get identified, or they come in too late that even when you do a surgery, it is such a painful episode for the child. So these are some of the pictures. We see anomalies from things like a hemangioma, as simple as a hemangioma, to so many other gross anomalies. But this is a picture of a child that was identified as a 9-year-old, well, identified to us, but probably they are there in the community and they had been treated as constipation since they had been born. This child had Hirschsprung's disease and he's coming to us at 9 years of age. He's lucky that he survived, but there are other complications that could have led to his demise before this 9 years of age. He was severely stunted, and there's all sorts of other complications that may follow. He was not growing and he'd never gone to school because of all the problems he's having with his tummy. We see, other things like bladder extrophy. And like I said, the complexity varies. We see children with diaphalia, we've seen conjoined twins. But again, a lot of these children are surprises when they get born. We recently had a set of conjoined twins who were born by normal vaginal delivery, and we just kept wondering how that mother managed. But there's miracles so many times, but you can imagine how she managed to deliver such children in a very low facility with probably just a midwife to assist her. The others, like we see such anomalies like giant nevi and with some of their complication, and this particular child had a giant nevi with neurofibroma. But some of these children, there may be syndromes associated, but we don't have the facilities to be able to do a lot of the genetic work that may name the exact problem they have or the potentials of the other things that might be associated with that. So because of some of the late admissions that we do get, this is just a picture of a baby who came to us at 14 days of age with an esophageal atresia. And when they do come to us late, the requirement for ICUs or neonatal intensive care rises up, and we don't have a good establishment for something like this in the public hospitals in the country. And so we have to resort to a schedule such as this. So the surgeons and the anesthesiologists, we do the surgery and then we make up a roster to look after their children. Something like this is not sustainable. And yet if we got some of these children earlier, we may not need to do support for their respiration. And so we may not need to resort to this, because if we are tired, we are not available to deal with the other patients. And then because of some of all these things that I've highlighted, we come to the Pediatric Emergency Surgical Course. The background of this was because we frequently received a lot of patients who had delayed referrals, and these were children of all sorts of ages. Referrals of cases that they should, they're also referring cases that they should manage. So a hospital that has a general surgeon would refer a patient maybe requiring a colostomy, or a 12-year-old with a typhoid perforation for whom a laparotomy could have been done, but also a child that needs a stoma for Hirschsprung's disease or anorectal malformation was getting referred after several days, yet the surgeons are equipped with the skills. We train them to be able to perform these things. So some of these things were not being performed. The other is the children would be transferred to us poorly resuscitated. And in some of the areas, things that they shouldn't touch or shouldn't bother doing, they performed some heroic surgeries and things many times do go wrong. And so they refer you to this patient with very little detail of what was done, but I call it tampering with things they shouldn't attempt. And so we decided that we needed to find out what the skill set was out there, but also develop something to help them know what they can do, what they should be equipped to do, and the things that they should refer and who they should be in touch with. And in developing this course, we felt that we should develop something that is contextual, because some of the interventions that might be out there in a textbook are based on Western literature, but there are some tricks that surgeons in our own environments have learned to be able to deal with some of the problems. And so we thought that some of these tricks might be helpful for some of these practitioners if they're having trouble, especially referring cases they should be managing, but also maybe identifying who should go where. And so in between 2015 and 2016, we performed a needs assessment. We interviewed, or we gave a structured questionnaire to general surgeons in training and recently graduated general surgeons about their comfort level in managing or different management for different common emergencies in pediatric surgery, as well as in identification of some of the anomalies. And from this, we were able to tease out the conditions that give them trouble, some of the challenges that they go through. And so it led to us designing a course that was based on what the need was, the referral patterns, and also what we identified as a need. So even those that had graduated seemed to be struggling, yet there's some things that we felt we had taught to them. And so this really included modules on perioperative management, neonatal emergencies, intestinal emergencies, and trauma, but not all trauma. And so the details of this course really just include the resuscitation of the sick surgical child, placing tubes and lines and analgesia for these children. You'll be surprised at how many times people don't know how to prescribe analgesia for children. Neonatal bowel obstruction, pyloric stenosis, and a bunch of other urinary problems, imperforate anus, cloaca and bladder extrophy, joint and bone infections, to mention but a few. And so when we carried out this course, we've so far had 3 of these courses. One was carried out in the center of the country, in the capital of Uganda, and 2 others, one in the north and one in the southwest. The course feedback we've had from this course was some of the reasons why they didn't do the surgeries they should be able to perform is because they lack pediatric equipment, and consumable supplies was identified as one of the biggest challenges. But also sometimes the expertise of their anesthesia providers was that they were not comfortable managing these children. And so they also requested that they needed additional hands-on training. So if we gave them such a course, because the course we gave them was didactic, at least the first 2, and so the next one combined an outreach so that there was hands-on training for some of the parts of the modules. They also requested that there's more frequent didactics, so not just one rarely given course, but maybe more frequently so that they retain some of this knowledge. And they also requested that we train whole teams. For example, if we're teaching the general surgeon and the medical officer, we still face problems because there's still late identification, because team members or healthcare providers like pediatricians, midwives, and nurses many times do see sick children with anomalies earlier than those with earlier than the surgeon. And so having them being able to know how to resuscitate, identify these children and resuscitate them appropriately would probably help us in identifying them early. The other thing, they requested that we have more hands-on training for them so that they could have more expertise. And so this is just a picture from one of our training courses, one that was in the Southwest. And this one was combined with an outreach surgical camp where the surgery is performed as well. And so from that, we've made some decisions about where we wanted to go forward with the course. And so we needed to perform an impact assessment of the course. Is it really doing what we expect it to do, or it's really, we're just wasting everyone's time and it's not doing anything? So actually we just started this, and we'll probably be going on for the next 6 months or so to be able to assess what this course is doing. We'll be able to assess referral patterns, the type of patients, the quality of the resuscitations when they arrive at tertiary centers, and if they are now performing more of the procedures that they should be performing at their own centers. This will all be part of, and we also do a test after some time for those who have already taken the course to find out how much knowledge they have retained. And we'll see what happens with this course. The other thing we've planned to do with this course is to share this course with other organizations. We've been requested to give this course to the Global Initiative for Children's Surgery, and I think we've shared the modules with them. We've also been approached by other surgeons in other countries, and we've been able to share the course content with them. It can always be tweaked to suit an environment, but it's something to work with. The other thing that we're currently working on is to develop a manual for both mid-level providers. This is really medical officers and for general surgeons, so that they actually have a reference tool. The course is not enough, but they need something that either is on their phone or a physical book that they can refer to when they're actually looking after these patients. The other thing that was requested for, and we realized that if we don't do this, we'll continue with later identification of cases, and this particularly pertains for children with correctable structural anomalies. We need to be able to, we were working on developing a course for nurses, midwives, and pediatricians. And this is really going to focus on early identification of cases, both the very gross anomalies and those that not obvious, that only show up with symptoms. For example, UTI in children is a surgical problem until proved otherwise. So they have to know exactly what to do when they're faced with such a child, and they have to refer them instead of treating UTIs. That is the wrong thing to do. The wrong thing is when once you identify it, you need to do an ultrasound, and then you send them off to someone who knows how to deal with whatever might be in there. The other thing, we're planning to work with the radiologists to update their reporting of their anomaly scans during antenatal care. And this, we may have to do some training in sites where there's already sonographers and radiologists, but also I think they'll have to change the way they train their techs as well as their radiologists when they're doing these scans. So this is a chart that we've identified, that we have adopted from one of the GICS members. And we have pictorials, and this is going to be one of the tools that we provide to midwives, nurses, and pediatricians, just pictures of some of the common anomalies. The others will also include some symptoms that they need. In part of their manual will include what to do when you get a child like this, and like that, so that it helps them. So a chart like this would be hung up on a wall somewhere, so that it helps them quickly identify, and they know this one should go here, this one's not compatible with life, this one, you know, this type of resuscitation is required, that is not the right thing to do. For example, if a child has gastroschisis, frequently we get children where the bowels are covered in gauze, but we're advising them to have something elastic, plastic, a urine bag to be able to cover and protect that bowel as they transfer the children to us. And yes, thank you.
Thanks very much, Dr. Kisa. That's great. There are a couple of questions coming in the Q&A. I'm going to ask that we hold our questions through to the end after Prof. Ameh has spoken, and then both panelists can address questions as they've come up. So what I'd like to do now, Prof, if you can start sharing your screen, I'll introduce you. Prof. Emmanuel Ameh is a professor of pediatric surgery and the chief consultant pediatric surgeon at the National Hospital in Abuja, Nigeria, formerly working at the Ahmadu Bello University Hospital in Zaria, Nigeria. His research interest is global surgery and access to children's surgical care in low-resource settings. And in this regard, he's published over 200 papers in peer-reviewed journals and worked on several book chapters. He's involved in the development of educational and training programs for the West African College of Surgeons, the Association of Pediatric Surgeons of Nigeria, and the Pan-African Pediatric Surgical Association. He was a commissar for the Lancet Commission of Global Surgery and is the current chair of the Global Initiative for Children's Surgery. He has recently led and concluded and launched the National Surgical Obstetrics Anesthesia Nursing Planning for Nigeria, which is the very first plan to include children's surgery and nursing as a specific component. And this is now being implemented. Thank you, Prof. Ameh. I will hand over to you.
Thank you, Emma, for those the kind introduction. So I'm going to be sharing my thoughts regarding the impact of pediatric surgery workforce gaps on congenital anomalies in sub-Saharan Africa. And a lot of what I'm going to be saying will be building on some of the things that Dr. Kisa already discussed. Congenital anomalies are presently the 5th leading cause of under 5 mortality globally, and majority of these congenital anomalies are surgically correctable. And you will notice from this this chart from the Global Burden of Diseases group that congenital anomalies are actually ahead of malaria and malnutrition in the cause of under 5 mortalities, especially in LMICs. And most of our work in sub-Saharan Africa as pediatric surgeons involves the treatment of congenital anomalies, the surgically correctable ones. Most of the time, more than 60% of our work involves the treatment of these anomalies. One of our recent work showed that about 1.7 billion children worldwide have no access to safe and timely surgical care. Majority of these children are in the LMICs, particularly in sub-Saharan Africa. So large numbers of children in our setting really have no access to surgical care when they need it. At the moment, the minimum density of pediatric surgeons required to ensure that there's adequate access to address the general pediatric surgical needs of the population. The currently recommended density is what obtains in North America. So that's what we use as the target. And the target we try to achieve is 1 pediatric surgeon to 100,000 population of children. Just by way of comparison, and I'll show shortly what is there in sub-Saharan Africa, United States presently has something like a surplus of pediatric surgeons, but you see one of the challenges we have in sub-Saharan Africa is that we really don't have reliable data regarding the surgical workforce and children's surgical workforce. But we were able to obtain some relatively comprehensive data, which was published in 2016. And the summary is that what we found is that most of the countries in sub-Saharan Africa had less than 0.1 pediatric surgeons per 100,000 population of children less than 15 years. But if you look at this table, you will find that the large countries, countries with relatively large populations in sub-Saharan Africa, Ethiopia, Kenya, Nigeria, South Africa, Tanzania, and Uganda have a huge gap. If you take Nigeria, for instance, as at 2016, we had a pediatric surgeons density gap of 767 pediatric surgeons. That's going to take many generations to bridge that gap. And if you remember that the birth rate in most sub-Saharan African countries is about 2.5% or even more. So the number of children that are born every year continues to increase, and it's impossible for us to catch up with producing the number of pediatric surgeons that are needed. Earlier this year, we have about 122 pediatric surgeons in Nigeria, 60 trainees, and our current annual production of pediatric surgeons is just about 4 to 8 per year. So you can see that it's going to take such a long time if we're ever going to bridge that gap. And I will show a little bit down the line how this is impacting on the treatment of surgically correctable congenital anomalies. And it's not only general pediatric surgery, huge gaps also exist in other key specialties that are needed for the treatment of surgically correctable congenital anomalies. Anesthesia, we really can't achieve much without anesthetists, but the numbers of even the general anesthetists that are available in sub-Saharan Africa is small, and pediatric anesthetists are even smaller in number. Number of neurosurgeons, especially those who are interested in treating children, is small. Cardiac surgeons, most of the surgical specialties that have to treat children, their numbers are so small. So that has significant impact on the outcome of the children that we treat. And I think that one of the big challenges is not just about the numbers. Even within countries, the distribution of the small available numbers is also a problem. Recently, when we worked on the National Surgical Plan for Nigeria, we looked at the distribution of pediatric surgeons and anesthetists in the country. And you can see the bigger the circle, the higher the density. But you can see that across Nigeria, most of the pediatric surgeons available and the anesthetists available are limited to the lower half of the country. And even where there are pediatric surgeons, there are simply not enough anesthetists to work with them. So creating a pediatric surgeon without creating an anesthetist is a huge problem. And we looked further, more closely, and we tried to look at what proportion of children are able to access a facility that has a pediatric surgeon within 2 hours of travel. And what we found was that the maximum percentage that can do that in Nigeria is just about 30%. So about 70% of our population, of our children population, really cannot get to a facility that has a pediatric surgery capacity within 2 hours. And this becomes a big problem when we are dealing with the surgically correctable congenital anomalies. As Dr. Kisa presented, many of them are anomalies that require urgent and emergency care. And you can imagine if it's taking more than 2 hours for them to get to a facility that has a pediatric surgeon. A few years ago, we looked at the impact, what impact this has on some of the common congenital anomalies. So we looked at our emergency neonatal surgical care, and more than 90% of our work, emergency neonatal surgical procedures, are for surgically correctable congenital anomalies. And majority of these are major congenital anomalies which cannot be treated anywhere. And if you look down here, you can see that some of the children are presenting to the hospital traveling up to 1,000 kilometers. That is several hours, almost a whole day of travel. So you can imagine a newborn that has gastroschisis or has an erectile malformation or esophageal atresia, having to spend several hours before they can get to a facility to be treated. And many of them, even during that transportation, they are not protected, they are not resuscitated. So the implication of this is that they are presenting late, the mortality is quite high, and even those who survive, they end up with long-term disabilities, especially those that have orthopedic anomalies or neural tube defects. They are unable, those that survive, many of them are unable to go to school, so they lose school hours, or they go to school much later in life. The parents, especially the mothers, are unable to earn because they have to stay with the children at home because it's difficult for those children to go to school. So the implication of the late presentation and the limited pediatric surgery density across sub-Saharan Africa, the implication is enormous. We also recently tried to look at further at what these gaps, the impact of this gap. But this time we looked worldwide using a log linear regression modeling. And one of the things we found was that scaling up surgical workforce in general, and this includes other specialties, surgical specialties and obstetricians. If they can be scaled up to 20 to 40 surgeons, obstetricians, and anesthetists per 100,000 population, we can prevent up to 500 under 5 mortalities annually. That's a huge number. And up to 60% of these avertable deaths are neonatal deaths, and majority of them occur from surgically correctable congenital anomalies. So how do we begin to even start to mitigate the impact of this challenge of the very small number of pediatric surgeons across sub-Saharan Africa? I think training is one of the crucial things that we need to do. We need to invest significantly in training, and just investing in training is not enough, because one size really doesn't fit all. So this needs to be done in a context-specific way based on the needs of various countries. And I think one of the key challenges that we have is ensuring that these children with surgically correctable congenital anomalies can actually survive right from the district and first level hospitals, because that's the first contact, those that require life-saving procedures. And that's one of the training for emergency care that Dr. Kisa and her team are doing. Will work towards achieving that, to make sure that medical officers, clinical officers, and general surgeons at district and first level hospitals can provide life-saving care for these children. But it doesn't end there. We must also invest in training specialized workforce so that they can provide a highly specialized care at the secondary and tertiary level. So one of the things we did recently in Nigeria was that we created the National Surgical Obstetrics and Anesthesia Plan. And for the first time, we were able to include children's surgery as a specific entity. And the intention is that, having done this, we should be able to begin to free up resources to invest in children's surgical care. If you look at the child health policies across most of sub-Saharan Africa, there's little or no inclusion of surgical care for children. And that's one of the things we are trying to advocate for and emphasize presently. As part of the implementation of our national surgical plan, one of the challenges we have in sub-Saharan Africa is that we don't even know the burden, the exact burden of these congenital anomalies. There are no reliable registries. So one of the things we did recently in collaboration with SmiTrain is to create a birth defects registry. And the registry is intended to generate data for advocacy, surveillance, and prevention. And we are starting with cleft lip and palate, and the plan is to gradually scale up to include other surgically correctable congenital anomalies in a selected manner until we're able to capture comprehensive data. So the platform I'm showing here, so this is live data from the registry. The registry is just a few months old. So this is the live data that is coming out of the registry at this moment. And we are hoping that in the coming years, we should be able to have reliable data on surgically correctable congenital anomalies in Nigeria. And hopefully this can be extended across sub-Saharan Africa. And I think that the work of SCAN should be able to begin to invest in creating this kind of registries. At the Global Initiative for Children's Surgery, one of the things we did a few years ago, maybe 1 or 2 years ago, is to create the optimal resources for children's surgical care. And the aim of this document was to focus on all the things that we need to do to improve the quality of surgical care that we provide. And a lot of it have to do with surgically correctable congenital anomalies. So it focuses with what happens right from the community level to advanced level of surgical care, with a lot of emphasis, especially at the district and first level hospital level, with a lot of focus on advocacy, training, and research. And we are hoping that in the coming years, This document can be used by countries that are planning to invest in children's surgical care to guide them in what needs to be done. The Global Initiative for Children's Surgery also is working actively with an organization called Kisa from Scotland, which is investing heavily in the creation of children-specific operating rooms. One of the big challenges we have across our tertiary hospitals in sub-Saharan Africa is that even where you have a pediatric surgeon, they simply don't have enough operating time to operate on the large number of children that come with congenital anomalies. So investing in creating specific operating room for children frees up space. And Dr. Kisa's hospital was one of the hospitals to have that, and several other hospitals across sub-Saharan Africa and other parts of the world presently are being given this kind of operating rooms. And hopefully that should significantly help in reducing the waiting time and the backlog of patients that we have with congenital anomalies that are not getting their surgery in a timely manner. So thank you very much for listening, and we are open to questions. Thank you.
Thanks very much, Prof. That's great. Thanks a lot. I'll just, if any people have any questions, if they can please raise their hands. And in the meantime, I'll ask some of the questions that have been put in the chat and which were sent to us beforehand. So there's a question from Anita Carr, which I think both speakers can answer. Is surgical care provided free of charge to families, and do the I suppose the budgets, the public health budgets cater for surgery for congenital anomalies?
So thank you, Emma. Maybe if I can go first. I think in at least in Nigeria and perhaps in many other sub-Saharan African countries, most parents pay out of pocket for the surgical care of their children. And that really is one of the huge problems that we face. We have situations where parents simply have to take their child away from hospital because they cannot afford the cost of care, since they need to pay out of pocket. Many parents end up becoming impoverished just because for a simple, even a simple repair of a hernia in their child. A few countries have insurance, but the problem with the healthcare insurance, especially at least in Nigeria, is the fact that most of it does not cover advanced surgical care of surgically correctable anomalies. Thank you.
Thanks, Dr. Kisa. Do you want to give us the situation in Uganda?
So in Uganda, in our public hospitals, we call them government hospitals. So surgical care is free for all, and at our center, surgery for congenital anomalies is free. But of course, not all consumables are provided, but it doesn't cost families more than something like probably about, should I say something about $20 if they have to pay for something. A lot of this, of course, some of our work is supported by our partners, bring us sundries and everything. But by and large, apart from the $20 in some of the consumables they may have to buy, everything else is free. And some of the tests they also have to pay for. But again, it doesn't cost them more than $20 at our center. On the other hand, in Uganda, there's several practices. There's private hospitals, like profit-making private hospitals. And if you walk yourself into such a center, do not expect free services. And you're expected to pay for the service there. And there's persons or families that prefer not going to the public hospital, and so they go to these places. Of course, there are some cases that will not be looked after in some of these places because either the treatment is so expensive, but also the expertise is lacking in a lot of the private hospitals. Then we also have what we call the missionary hospitals. Many of them are faith-based, Catholic, Anglican, Islamic, these hospitals. And for some of them, services are subsidized. to such low degrees, not all of them. And so again, many of these hospitals are in hard to reach areas, so they may perform the emergency procedures, but the reconstructive surgery may wait for a camp of visiting surgeons, or they refer them to our center for surgery. Thank you.
Thanks very much. And I can also speak for South Africa. We also have a public sector and a private sector. And if you have health insurance, the private sector can take care of things because it's prohibitively expensive. And then healthcare is free at the public hospitals for children under 5. And then after that, depending on income. But there are, I suppose, this kind of expertise is limited to the larger centers and the sophisticated hospitals. Thanks very much. And now a question that I suppose Prof. Ameh can answer, which came earlier. How does he suggest that one improves the role of nurses in caring for children with major surgery? And maybe your experience from your program can speak to that.
Thank you. I think nurses are very important and crucial, both right from the ward nurses and the operating room nurses. They are so crucial. And for us in Nigeria, there is a specific pediatric nursing training program that creates nurses or produces nurses with expertise in the nursing care of children. And there's also an operating room nursing training program. But the challenge is that the numbers are small, and many times in most facilities, the nurses is the same nurses that take care of adults that need to take care of children. And what that means is that frequently there are gaps in care. But one of the other things that has happened is that the advance and training and progress in pediatric surgical training has significantly left nursing behind. And we are at the moment trying to see how we can bridge that gap, because I think that when we train for surgical care of children, we need to train a team, the pediatric surgeon, the nurse, and the anesthetist. Otherwise, the pediatric surgeon simply either does not have the anesthetist to work with, or he doesn't have the right nursing expertise. So you do a very complex reconstruction for a congenital anomaly, and the nursing care, if there are gaps, then the outcome is going to be a problem. So I think that as we advocate for training, advocacy should be about training the entire team of a pediatric surgeon, the nurse, and anesthetist, rather than just focusing on the pediatric surgeon. Thank you.
Thanks, Dr. Kisa. Does your program also include nursing staff?
So, I mean, there's no specific training for pediatric surgical nursing, and we actually face a lot of problems in Uganda because the administration for nursing is completely different from the physician's administration. And so they shift them every so often at will. So you will train a team, they know what you want, both in the operating room and on the floor in the unit. And before you know it, they've been switched. And so we continue struggling with that. We're trying to advocate for people to leave the nurses that we have trained, or those who really want to stay with the pediatric surgical service. But it's getting harder and harder. But Professor Ameh is very right that pediatric surgical training has gone ahead, but we're still few, and anesthesia is coming as second, but the nursing has lagged behind. But also with these frequent switches, it really doesn't. Many times you invest in a given person and they've switched them to some adult TB ward. It's quite demoralizing that you train this person, they don't want to move, but then they've been moved. But that is by a different set of administration in the hospital.
Thank you. There's also, I suppose, a comment in the chat, in the Q&A, that looking at high rates of gastric schisis, and does anyone know how rates of gastric schisis compare with those of congenital heart disease?
I mean, we actually don't know, because at our center, unless Professor Ameh has from his own center, but from our center, we have a cardiac center or heart institute, and all the children that are identified by pediatricians or at birth with congenital heart anomalies, they're managed from there, and they manage them kind of in isolation from the rest of us. So we actually don't know, we've not kept track of their rates. While, for example, we can compare, let's say, gastroschisis compared to anorectal malformation in our own center. And in regards to its actual high rates, like just our cohort of 7 years, we had about an average of 40 gastroschisis a year. And we've compared that with data from the US over the same period. And for 14 hospitals, they had a similar number for 14 hospitals over 7 years. And for us, just one center, we had about 240. And I think there's a lot more who are out there, maybe dying there, not getting identified, victims of infanticide and the like. But the rates compared for heart and the other, I have no idea.
Thank you. I think it's the same situation for us. I think the challenge with that comparison is the fact that many of the infants with gastroschisis probably die before they get to hospital. So we really don't know the numbers that reach the hospital. We think that is just a very small fraction of the actual number. While on the other hand, majority of the babies with cardiac anomalies, many of them survive to get to some treatment center. So it's very difficult to compare. We simply don't have enough information to do that comparison.
Thanks very much. I'm not seeing any further hands. So that said, I'm going to hand over to Dr. Bala Morsha to launch the scan website. Thanks. Over to you, Linda.
Thanks, Emma. Thank you very much to our presenters. I think we've heard a lot today about the challenges that are faced in pediatric surgery. And today I'm happy to say that we are going to launch the SCAN website, long-awaited SCAN website. And as Emma presented earlier, SCAN is the Sub-Saharan African Congenital Anomalies Network that is funded by UKRI MRC. And this website has been put together in collaboration with the Global Health Network. So on our website, it can be reached down here. This is our URL, www.scan.tghn.org. You'll find our homepage where you'll learn about us. Currently, there are a few resources that are up, as well as an area for our workshops that we hold and some current articles of interest. So this is an evolving website, and things will be updated as we go along. So we are very happy that you're with us today. And if you're interested to join, you can just click on the Get Involved, and you can either join in and register to be a member of the hub, or if you're interested in joining SCAN, there's a short questionnaire where you'll put in a few details, and then the SCAN team will get in touch with you. This network is growing, it's evolving, and as we grow, we're also putting together criteria for membership, and this will be shared in the months to come. We also are going to have features for updates of upcoming events. For example, this is the workshop or webinar that we had today. And every Wednesday, every month on the last Wednesday, we are having webinars, and you will find the registration at this section of the website. You just click on the register now, and that will get all the information you need to be able to join us with the webinar. We also have previous webinars if you missed them. This is the 5th one, and it will be uploaded in the next week or so, but all the previous ones are currently on the website. So feel free to listen and see what information has been shared. There was a question about prevalence of birth defects in some of the countries, And some of this has been presented previously, and you can get the updates here with the recordings. So coming soon will be more resources. I think some you've heard today. We're hoping that we'll be able to add those in regards to surgical care for children with congenital anomalies. We're also going to include articles of interest, and we'll have a members area once that is up. We're also going to put together a map of Africa that will show the congenital anomaly surveillance projects and where some of the experts can be found, as well as support organizations with their contacts. And last but not least, SCAN, one of the objectives for SCAN is to do collaborative projects. So as the projects evolve, we'll also have those uploaded on the website. So if you would like to contact us, that is our email, and we are looking forward to hearing from you. Please share this with people who you know are interested in supporting children with congenital anomalies in Africa. So thank you very much. We're looking forward to hearing from you. Over to you, Emma.
Thanks very much. That's great. And so I think some of the queries that we had in the chat about getting involved or accessing our resources, I think now that the website's been launched, there's a lot of information there, and feel free to contact us with any queries or if you're keen to participate. With that said, I'd like to thank our speakers very much for their participation. There's just been a note in the chat, if you could give us some feedback by completing a survey, which the link is in the chat. And yeah, this is very well attended. Thanks everybody for coming. Thanks to our presenters. And we look forward to seeing you again the last Wednesday of November. Thanks a lot. Bye-bye.